Good morning, everybody. Thank you so much for joining us, our third 2023 Nurse Practitioner Summit. And I absolutely get the point that you guys are taking a Saturday in December to spend time with us. So we do not take that lightly, and we are honored and grateful that you have joined us today. You are going to hear from some amazing speakers who I've gotten to hear a couple of times already with great information. And on behalf of Integrity Continuing Education, I just want to take the moment to welcome you and tell you that we currently have 650 nurse practitioners signed up for our virtual CE Summit. So thank you, thank you, thank you. I cannot say it enough. So let's start. My name is Brett Snodgrass. I am a family nurse practitioner. I have just recently completed my doctorate at the University of Alabama, Huntsville. And I've been a family nurse practitioner for 16 years, a registered nurse for 26 years. And I am currently Director of Operations for Palliative Medicine for a large hospital system, the Baptist Health System in Memphis, Tennessee. And I'm honored to kind of be that operations director and really work with patients with chronic life-limiting illness as a family nurse practitioner. So that's kind of who I am and what I do. I speak and teach nationally, so I'm honored to kind of spend the morning and early afternoon with you as we talk about important things that you need to know and things that are important to nurse practitioners. Provider statement, of course, you're going to get continuing education, free continuing education from Integrity Continuing Education. As you can see here, we work in conjunction with Global Education Group, UMA, to provide you with your continuing education. And we're going to talk about how you're going to be able to get that continuing education kind of as we move along. Program supporters, Actelion Pharmaceuticals, GRAIL LLC, and Merck Sharp Dohme are supporting with educational grants, making this a possibility to be a free continuing education, and we're thankful for them. Our educational partners, I have to send a very special thank you. We love all of our nurse practitioner networks and associations across the nation. Specifically today, we've partnered with Florida Nurse Practitioner Network, Maryland Academy of Advanced Practice Clinicians, the Nurse Practitioner Association of New York State, and Pennsylvania Coalition of Nurse Practitioners. They are our educational partners. Many of you are likely from these states and a part of these associations. So thank you to you. You have helped us get here and be able to provide this education. So thank you. Okay, important things. There are two ways to view our continuing education presentation today. One is live, which many of you are on our live webcast. Probably the easiest way to do it, and here's why. To get your continuing education, you're going to view our program content. As we begin each new presentation, you're going to have pre-test questions being pushed to you. We ask that you answer those. And then at the end of the presentation, you will have post-test questions. And finally, at the very end, you're going to complete your evaluation, and then you'll get a link to a final evaluation form that's going to be at the top of the screen at the end of the program, and then you will get your continuing education. So that's simple. So if you are viewing through the live webcast, this is exactly how you'll do it. Now, if you're joining us, and we're honored if you are, through social media simulcast, Facebook, Twitter, LinkedIn, any of those, you can view the program content, but you're going to have to get pre-test, post-test, and evaluations emailed to you, and you'll have to complete those, and then you will then get your CE certificate emailed to you. Now, if you are viewing on any of these platforms, you can absolutely click to join us live, and it makes it just a little bit easier for you, but we're happy you're joining us any way possible. All right, let's talk one more time about the polling questions. The webcast contains these real pre-test and post-test polling questions. Again, this feature isn't available if you're on Facebook, Twitter, or LinkedIn, okay? And you're going to get those sent, you'll get links to the pre-test, post-test. But if you're viewing live, you will get those pushed to you in the pre-test. They'll be available at the post-test, which all the speakers are going to talk about. You'll answer those polling questions just by clicking on the button that contains your preferred response. And in a minute, we're going to try the feature out so you get comfortable with it. Social media viewers, here you go. If you're viewing us on social media, it's fine to stay there. But if you wish to join us live and to be interactive with us, we would ask that you go right here to www.integrityce.com/NPS3. So you see that link right below here. So please join us if you can, so you can be a part of the interactive event. All right, let's try out the audience polling questions. We want to know a little bit about you. So which of the following most closely describes your practice setting? Hospital network, institutional settings such as skilled nursing facilities, correctional facilities, mental health hospitals, psychiatric units, retail pharmacy, urgent care, private practice, group practice, or other. And if you're in another setting, go on and type that in the chat box for us. All right. A lot of people in hospital networks right there with me. And next is private practice, very common, and others. So I want to know what you're doing and where you are. All right. What is your professional specialty? Primary care, family practice, or acute care? Adult, geriatric, long-term care, cardiology, oncology, hematology, pulmonology, respiratory, or other? Arousing. So when we talk about professional specialty, much of us are in that top category: primary care, family practice, or acute care. That makes up many of us. And then many of us are specializing in other places, such as myself in palliative medicine, but of course, long-term care, cardiology, oncology, and pulmonology, and others, because you're everywhere. And thank you for doing the work you're doing. All right, let's move forward to the keynote presentation. All right, so I am thrilled and honored to present to you guys the keynote presentation for today's event. And I'm going to be talking about the past, the present, and the future, but staying relevant and resilient. I'm going to share with you that I survived COVID through the pandemic in the hospital, much of the time in the ICU, with probably the sickest of the sick patients. We had a small ECMO unit, so we had patients on ventilators and ECMO and very sick patients. And I spent that time there. And I will tell you, I believe that time, and you probably can all agree, and I'm not going to spend all our time talking about COVID, but I think we need to talk about how it has shaped us as providers. Because whether we like it or not, it has shaped and changed how we practice and kind of our resiliency and kind of what were the effects of all of this on us during that time. So I'm going to spend some time talking a little bit about it. Really, how did we get here? I've never been a big fan of the concept of resiliency. I'm just always a put your head down and work really hard. But you know what? I found that we needed to begin to think about burnout. And for me personally, I had to think about how I could stay resilient and relevant and be present with the patients that I'm taking care of. So again, you know me, I'm Dr. Brett Snodgrass. I have an award-winning blog. Blogs are kind of going by the way. I am on most social media sites. I actually do have some presence on TikTok as a nurse practitioner, kind of spreading the word about what we do and where we are. So if you're on TikTok, find me. But I'm on LinkedIn, Facebook, Twitter, all the things. I love to connect with other nurse practitioners, and I find it is so, it's something about resiliency for me to be connected to you. I think the job we do is hard, so let's connect. So please don't hesitate to connect to me, find me on social media. I do have one disclosure to let you know. We'll not be talking about any of the products that I work with, but to let you know, I am on the Speakers Bureau for Salix Pharmaceuticals, just so you're aware. All right, what are we going to do for the next 45 minutes or so? So our learning objectives are to summarize the evolution of nurse practitioners in the United States healthcare system. I think it's so important to look back and see where we came from. We can kind of get blinded, and we can wear blinders when we're in the middle of healthcare, but I think it's really important to look back where we come from. We're going to look at individual and workplace factors that are truly influencing our well-being, explore the importance of boundaries in the midst of a crisis, and really characterize ways that wellness can foster within your team, and even more importantly, within yourself. And I'll tell you, if you're a leader, this is even more important, because when you are a leader, when you are in administration, you have to not only be present for yourself and keep yourself resilient and prevent burnout for yourself, but you're also doing that for your team, and you play a role in that. So what can we do to foster best practice to best care for our employees as well, not just our patients? So we're in a lot of places. All right, the pre-test polling questions should be going out to you, and you should be getting those now. So let's take a little bit and look at kind of the current landscape of practice. Where have we come and where are we going? Not only just nurse practitioners, but let's just look at healthcare as a whole. 101 million patients currently are without adequate primary care access. And you probably can all shake your head and say, absolutely they are. Now, who is caring for many of these patients without access or with low access? It's you and I, right? 101 million patients. Why? There is a lot of patients that have low income employment that doesn't provide healthcare for them, so they do not have access, nor can they afford, oftentimes, access to healthcare. We also have rural communities that do not have access to primary care services as much as they have in the past. So again, we have to go and treat the patients where they're at. Interestingly enough, we even more so of a problem, 165 million patients are without adequate mental health services. And I think we can have a resounding absolute, right? What are we seeing? We are seeing many patients that are being treated as best they can with maybe in primary care that really need specialty service that we do not have access to. Now, one of the things over the last 10 years has really been the evolution of the psych nurse practitioner certification and specialty. Thank you. If we have psych nurse practitioners on currently, I want to say from me to you, thank you for doing what you do, because what we know is we have such a limited access to mental health. I want to share a quick story just to kind of illustrate that issue. I have worked in palliative medicine, hospice, and chronic pain for many years. And interestingly enough, probably from 2014 to about 2019, and today even, there's been a talk about opioid prescribing and opioid overdose deaths. And the idea came that we need to make providers prescribe less, and if they prescribe less opioids, what will then happen? Overdose deaths will go away, right? In fact, we saw the converse happen. What we found was, in fact, every single year since about 2015, opioid prescribing has slowly decreased. Appropriately so in many cases. We could have a whole conversation there, but really what we've seen is that opioid prescribing by your prescribers, by us, have been decreasing. What have we seen with opioid overdose deaths? In fact, we've seen the opposite. We've seen opioid overdose deaths go up. And I would implore to you that we have less of an opioid problem and more of a mental health issue that oftentimes has been treated with opioids in the past. Now, I don't want to villainize you if you prescribe opioids. I prescribe opioids in appropriate patient populations. So I want to be careful there. But what we found was, in fact, it was not the problem of the prescriber. It was not the fault of the prescriber. And amazingly enough, it did not switch the problem and take care of the problem. But in fact, opioid overdose deaths continued to increase. And what we found was lack of mental health services was part of this continued increase. So we have to work to change all of this. We need access to primary care for our patients. We need our other patients to have access to mental health services. And not only that, why? Because our problems are going to continue to be here. They're going to continue to rise because we have an aging population. 80.8 million Americans, or not Americans, this is population. I'm sorry, this is Americans, sorry. 80.8 million are aged by 2040 will be 65 years of age or older. That is 1 in 5 Americans will be 65 years of age and older. What does that mean? We are doing a bang up job of keeping patients alive longer. We are good at that. And healthcare has come a long way. We're proud of those numbers. Yet, what we oftentimes have is having an aging population. We're going to have driving up healthcare costs because they can be costly, because oftentimes there are chronic illnesses that we can keep patients alive longer, but yet it comes with a cost, right? But also just the sheer number of patients that are going to be older patients. So we need access to primary care. We need access to living facilities for those patients. Oftentimes we need to be able to care adequately for the aging population. So we think we have a problem now with primary care access. If we continue on the trajectory that we're going to have a major problem in the next 10, 15 years. Now, here's the problem. By 2026, there's going to be a shortage of up to 3.2 million healthcare workers. And I want to stop here and say something, because oftentimes we see that the number of NPs are rising very quickly. And we do see that. What we want is educated, prepared nurse practitioners coming out into the workforce. But as you can see, even though we have a rise in the number of nurse practitioners coming out, we still have a major shortage issue going on, and we're going to see that happen. So I don't think that is as big a problem sometimes as we make it, with nurse practitioners, coming out quickly into the work, not quickly, but coming out in large numbers into the workforce. We need them. And here's why. A couple of things to know: NPs and PAs are among the most in-demand health professionals. So while we are seeing more coming into the workforce, we're in demand, right? But also, what do we know? U.S. News and World Report, we oftentimes get a lot of our information there, has ranked nurse practitioners as the #1 best healthcare job. Now, I hope many of you are saying, absolutely it is. I love what I do every day. I can say, absolutely it is. I love what I do every day, but I recognize that what we do is hard. But I'll also tell you, a lot of the other providers and a lot of the others have hard things going on as well, and hard issues in their specialty as well. So know that you're not alone, but advanced practice providers have an all-time high satisfaction and confidence rating. We have great outcomes, and we show that we are doing good work. So once again, thank you for what you are doing. Please keep doing it. And we need to continue to educate those coming behind us. We need to pour in to the nurse practitioners that are coming out of school, so that we have America and our patients great healthcare providers when we are ready to leave this profession. We're ready to move toward a retirement. We're not getting younger. And we need to pour into the younger ones that are coming up. So if you are new, here's what I'll tell you: latch on to some seasoned nurse practitioners. Find a mentor. That changed everything for me and I'll just give you a quick plug. This is actually from the American Academy or American Association of Nurse Practitioners, this landscape and this map. But I advocate for American Association of Nurse Practitioners every single day, because I think you need to join your association and you need to network and be mentored. best thing I ever did. I was greatly mentored, and I've been greatly mentored. I continue to be greatly mentored by nurse practitioners who've been doing it longer, who are older than me, for whatever, find you a nurse practitioner that can be your mentor and kind of walk with you through this, because I think that's where your success lies. So there's my quick free plug for American Association of Nurse Practitioners. It's a great association. But let's look at the APP landscape. This is specifically nurse practitioners. So this is the nurse practitioner landscape of full practice authority. If you don't know what full practice authority is, you need to know what full practice authority is, because you know what? That dictates how you're going to be able to practice in whatever state you live in. How we can practice as nurse practitioners differ depending what state you hold a license in. And that changes everything. Physicians do not differ in how they can practice from Tennessee to Mississippi to Montana, right? Nurse practitioners, every single state, it differs in how you can practice. If you can see it, kind of looking at the right side of the map, you'll notice different colors. You see reds and yellows, and what that says, other than California on the left-hand side, but what that tells us is there are still, 23 states that do not have full practice authority. That means that at some level, a physician must co-sign, supervise, co-manage patients with nurse practitioners. So one profession has to oversee another profession. It'd be interesting if electricians oversaw plumbers, right? It'd be interesting if speech therapists oversaw physical therapists. That sounds so crazy. But in fact, we have physicians that have to oversee nurse practitioners for our practice, despite the fact that in these states, we are certified, we have continuing education, we do all the things to meet our practice authority. We've set for our board certification, we are certified, we practice, and we are educated. So it's interesting, we need to move this forward. If you don't know enough about full practice authority, I want to challenge you to learn about full practice authority. It does not mean that your practice changes in the state that you live in necessarily, or your day would change if that state got full practice authority, but it does give the ability for more patients to get care from nurse practitioners in those states. So as you can see, I'll just share, I live in Mississippi. I practice in Tennessee and Mississippi, and you can see both of those have restricted practice authority, meaning I have to have some type of oversight in both of these states. Now, in both of these states, I can own my own practice. I can open my own practice, but I have to have that overhead of paying for the oversight that the state requires. I'll also add that there is no research that supports that oversight provides better care or safer care or more cost-effective care. But what it also does is, when there is oversight that's required, there's also money that must be paid from one profession to another for that oversight. I wouldn't want to give it up either. So the fight continues, if you will. I will tell you that each of these states that you see in red and yellow are working at the state's level to move forward and to move legislation, because that's what it requires. It requires state legislation to change practice. So we need to support this. You need to support your legislators, senators, House of Representatives that support nurse practitioners. You need to in turn support them. And you need to work with your state associations, whether you have a state nursing association or a state nurse practitioner association. Find the association that has a lobbyist and work with them, because that is how we will move forward full practice authority. I remember I was so excited when more than half of the states in the US got full practice authority. So the momentum is going, it is coming. Each of our states are working on this if they don't have it already. And here's what we know. Nurse practitioners have either graduate and or in many cases doctoral level educations. We know in every state they can evaluate and diagnose patients. They can order, interpret diagnostic testing, and they can initiate and manage treatment, including prescribing medications. Now, I know you're probably saying, I know all of these things because I am one, but just remember, we are doing important work. Let's keep the work going. So I challenge you to get a hold of your state association and work toward full practice authority. The Future of Nursing was a report that came out. We see that come out every few years, probably every 10 to 15 years. And this was kind of Future of Nursing 2020 to 2030. And they come out and they really want to begin to kind of lay the foundation of kind of what nursing needs to look like for the next 10 years. And this was interesting. The emphasis is usually always patient focused, right? So in this report, it looked at social determinants of health, health equity, but two things became more apparent. It talked more about diversity in the workplace and health and well-being of the nurse. Interesting. You know, oftentimes we're talking about how we best care for others, do for others. Everything is about everyone else. But my friends, if we don't take care of ourselves and or each other, we are not going to be able to run the race and continue to do what we do. So just know, it's interesting that now we have these national robust reports saying, take time for yourself, take care of yourself, and keep yourself healthy. Now, how are we going to do it? It's through research, education, technology, and removal of barriers. That goes back to full practice authority. So I challenge you, if you had a moment, look up the National Academy's Futures of Nursing 2020 to 2030. You know, I'm honored to have a daughter that had graduated in May as a registered nurse, passed her NCLEX. I will tell you, it was a little bit like PTSD going through it with her. But I've got to watch the new generation of nurses and really meet some of her classmates and really get into the trenches and kind of reteach things with them during that time. And I am so excited to see what the future of nursing looks like. It's bright. And these are some amazing nurses coming out. So we're going to be okay. But we got to take care of ourselves and we need to take care of our nurses coming forward. So what are the challenges? Let's take some time here. And this is where I'm going to kind of change gears and really talk about pushing home and convincing you that we have challenges. We know it, but we've got to care for ourselves. So let's look at external challenges. You probably could name a whole laundry list, but a few things are time, the pressure, high demands at work, lack of freedom to make decisions. We oftentimes are in these kind of bubbles in healthcare where we don't always have the capability to prescribe the medication we want, maybe because of insurances and issues, but also in entities, they sometimes can control that. Absence of social support. We need to think about how we can reach each other. Lack of role clarity. And I hear that a lot really in my hospital system is really our role clarity. It's interesting that, you know, the nurse practitioner, there can be confusion as to roles. Clearly there's role clarity confusion between physician assistants and nurse practitioners, between physicians and nurse practitioners. And so that can truly provide confusion for all of us. In some instances, it's lack of resources, a bad atmosphere. So all of these things and others are kind of those external challenges we're facing every single day that we're working to try and fix, but really working to navigate through. Because ultimately, that's sometimes what we have to do is navigate through those. Or it says, you know, a bad atmosphere, sometimes we have to leave bad atmospheres. Or how do we make the atmosphere better? Now, our internal challenges are kind of what's going on with ourselves. We have high self-expectations. Why? Because we're nurses. We know that, and, you know, I'll go back and say the registered nurse education has been ranked in college campuses as the hardest and the most robust and difficult degree to get. So why? Because we have high self-expectation, and we should, but we have perfectionism. Those are the people that are going into nursing. We want you there. We want perfectionism. I don't want somebody coming in and just kind of figuring it out along the way, but that is huge pressure on ourselves. So we have to recognize that and really begin to deal with it. Suppressing our own needs, isn't that just a nurse, right? What do? We care for others and others and others, and we do it oftentimes in the name of not taking care of ourselves, not taking care of ourselves physically, not taking care of ourselves mentally. And we do it in the name of healthcare. So we have to be really careful. And I want to call this out so that we begin to think about ourselves. I want you to take a minute and think kind of what are my external and my internal challenges? A strong need for recognition. We need that. Do we hear a lot of it? Do we hear a lot of thank yous? Sometimes. Interestingly enough, in COVID, early on, what were we? We were the heroes. There were people clapping as we walked out of work. There were people bringing, every place was bringing food, all of those things. That was early COVID. What happened later COVID when we got vaccinations, when we got different treatments, when we got, maybe better ways of treating things? What then began to happen? Quite the opposite. We were no longer seen as the heroes, and we were really being seen as potentially something less and something that wasn't doing, we weren't heroes anymore. So it really got to be this feeling of what is our meaning and what is our, who are we and what are we doing? Oftentimes, and I'll tell you, I'm very guilty of this, work as a substitute for a social life. I love to work. I love what I do. I love being a nurse practitioner. I love doing these things. I love speaking and teaching. And I've really kind of treated that personally as kind of that being my social life. Now I have amazing friends across the nation who are nurse practitioners. So you have to take all of this into consideration. Other things of always wanting to please others, we do that. Feeling irreplaceable. If we don't do it, no one will. I assure you, if we leave our job tomorrow, somebody will replace us. And really all of those things. So take a minute and really think, what are your true external demands? What are your true external challenges? And what are your own internal challenges? Because we have them all. And these things, this is really kind of being self-reliant and self-reflective. And that in and of itself can be positive, doing this hard work that we do. All right, so how did we get here? Let's talk a little bit about kind of some research that's come out of COVID and that's come out of the last few years. So this says, and this is a little bit older slide, but it said vaccines may be on the way, but vaccines are here, right? But there's been a confusion and concern with the pandemic. Again, early on, two things kind of hit. There was really two pandemics. We know there was a physical disease pandemic, but there also came from that kind of trauma and exhaustion to healthcare providers. So vaccines came, and again, we were heroes before that. And then after that, as we began to talk about vaccines and treatments and things like that, we kind of began, in some instances, to be villainized. We had to begin to and it caused kind of trauma and exhaustion. We had to begin to think about this a little bit differently. But then the question came out, has the government done enough to help alleviate our stress? Yeah, I don't know that they have. I don't know the role that they play. What role do we want the government to play? But there was that question of really the frontline workers being burned out, but still having a job to do. What do you do? Let's think of the moment. Think for just a minute. Again, we don't want to, I'm very much one to want to leave COVID and the pandemic in the past. What I can tell you is what I'm seeing in the hospital right now. And this COVID numbers are increasing somewhat. Nothing like it was when we didn't know what it was and early on. But yeah, we've seen kind of a bump in COVID numbers. It always gives us a little PTSD of, oh my goodness, are we going back? But I want you to take just a second right here to say, what are 3 ways that the pandemic impacted your well-being? And what of those things are really worrisome? So let's look at kind of a Medscape report about nurse practitioners in 2022. So kind of the tail end or kind of that decrease of COVID, we began to look at nurse practitioners specifically to say, tell us how you're doing now. Of course, we looked at where they're working and how they're working. Are they full-time? Are they part-time? Interestingly enough, many of these, even if you're working full-time or part-time, it wasn't significantly different. Many felt burned out. It was easy to feel burned out. Now, burnout can be a very temporary thing. Depression is concerning because it can be more of a long-term, ongoing thing. But many, 1/3 of all participants in this, that they were currently burned out. A little bit less if they worked part-time or per diem or PRN, but nonetheless, they were almost as burned out as those working full-time. Depression, you can see a small amount, but still there, which is concerning. Both burned out and depressed, that was there. And 1/3 said none of the above. So 2/3 of all nurse practitioners were affected some way and were experiencing some type of burnout, depression during the last few years. I think we could all say, of course we were. Let's define burnout just for a minute so we kind of have this working knowledge. Burnout is a state of physical or emotional exhaustion that also involves a sense of reduced accomplishment, lost personal identity, interestingly enough. It's a syndrome conceptualized by chronic workplace stress that is not successfully managed. So things a person might be feeling, things you might be feeling, feelings of energy depletion or exhaustion, an increased mental distancing from a job, almost like being a robot, just going in and doing the job, feelings of negativism, cynicism related to one's job, or reduced professional efficacy. We don't feel like we're enough, and it's affecting our work and our lives. Interestingly enough, this phenomena is really an occupationally contextual. So not really experienced in other areas of life as much, but burnout is usually related to workplace or job stress. How long have the nurse practitioners been burned out? Okay, remember this was 2022. The pandemic was in 2020 to 2022. Interestingly enough, 1 to 2 years. So we can say that this pandemic really has had a major impact on nurse practitioners feeling burned out, nurse practitioners being exhausted, not just an exhaustion you can go to sleep and wake up from, but truly kind of a physical and mental exhaustion. But you can see many nurse practitioners began this and really felt this. And I think that's when I really began to feel it was during the pandemic and moving forward. So they asked, are you more or less burned out than during COVID quarantine months? Interestingly enough, we are now in 2022 more burned out. And, that's been an interesting phenomenon. Of course, let's talk a minute about quarantine months. For us, none of us, most of us, unless you were in outpatient clinics, then you oftentimes went to telehealth. But for many of us that were in the hospital, nothing changed. We weren't quarantined. In fact, we left the family at home and we were the ones that went out. Interestingly enough as well, you can talk about quarantine a little bit of what it looked like, because for many adult children, older children came home. Mine came home from college. I had a senior in high school and I had one that was a sophomore in college. And so my senior was home during her senior year. That's how her senior year played out. The other one from college came home. So we had everybody at home. It was kind of an interesting time, kind of almost a good time in that everybody was there. We were all together during this time. I know that didn't play out like that for everyone, and some people were very much isolated during that time. But as you can see, what we've seen over the period is that the burnout is becoming worse, or has been worse since those quarantine months, for a number of reasons. Also, I'll add, during the quarantine months was when we had kind of that hero phenomenon in healthcare. So we were being lauded, we were being praised, we were being talked about, we were being fed, we were being all the things. And then once quarantine lifted, it was status quo. Everybody went back to work. So there wasn't as much talk about what we were continuing to do, despite it still being difficult. And despite, even after the vaccines came out, we were still having significant amount of deaths, specifically related to those that chose not to take a vaccination. But I'm not here to have a vaccination debate with that. But you can see it's just really affected and continues to affect since quarantine months. And what's continued to NP burnout? Well, if you look at this, really not much has to do with COVID. It's all about the environment. Too many bureaucratic tasks, charting, paperwork, about 50%. That is contributing to the NP burnout. Now, do we need to chart? Do we need to write down what we've done? Do we need to do all of that? We have to do that. How can we do that and continue to be resilient? Interestingly enough, kind of how I set up my day in the hospital, and I'm a director, but I'm also a clinician. So on many days, I see as many patients as all the other providers in our palliative medicine program. And so I remember walking back to the office last week thinking, okay, I have about 2 to 3 hours of charting left. I'd seen all my patients. I've had all my family meetings. I've done, many of the things I needed to do. I kind of save a lot of my charting for the end of the day, but I knew going back, I had about 2 to 3 hours worth of charting to do. So what that tells you is that's really about easily 1/3 of the day is going to be set or is going to be set forward doing bureaucratic tasks like charting and paperwork. So it's there, it's real. Now there's conversation about insufficient compensation and salary. There's still a conversation that we need to be paid, interestingly enough, more than what we're paying. And I don't disagree with that. Interestingly enough, with Medicare, we get 85% of what physicians do when we bill. The current set is on average, we're paid about 80 to 85% of what the physician is for a visit or for whatever we do with our patient. We're not, interestingly enough, paid 80 to 85% of the salary of a physician. Maybe that's a conversation for later, but I think we need to talk a little bit more about being paid more closely to what we're getting reimbursed for. Then lack of respect, administrators, employers, colleagues, or staff. You go into large hospital systems and you can oftentimes see that there may be less respect for the nurse practitioner or the physician assistant, the advanced practice provider position. And you oftentimes see things are being done for physicians and for, less about providers, more about physicians. So there can feel to be a lack of respect, not only from the administrators, not only from the top down, but also from colleagues and staff. Now there's a conversation about too many hours at work. Lack of respect from even patients. And then going back to COVID-19, the stress of social distancing and societal issues that have related to COVID-19 talk about us no longer being heroes. So a lot of things have contributed it. Now we might look at this list. What things can we change? What things can we not change? One, we need administration to know these things as well, so they can help us change the things that we cannot change. Some of these things change, but some can't. So what can we change to limit or lessen NP burnout? So how does it affect their personal relationships? Well, of course it's affecting them. 70%, 2/3 of patients of nurse practitioners, it's affecting their personal relationships. So how are nurse practitioners dealing with burnout? Well, you'll look in this list, and there are some positives of way you're dealing with burnout and positive, and that's probably keeping you resilient. And there's some negatives. Let's look at them. Talking with family members and close friends. Many are doing that. About half of nurse practitioners are doing that. Now, that's a positive, right? Sleeping, getting good rest, exercise, all good things. Playing or listening to music, all good things. But then we talk about isolating ourselves from others, eating junk food, playing or drinking alcohol, binge eating, negative things. So you can see there's as many positive things that nurse practitioners are doing to deal with burnout than negative. So you need to take a moment and think, how am I dealing with these things? And maybe change around what you're doing, add in some positive ways to begin to deal with the burnout, so that you're not, affecting yourself physically as well. Someone said that COVID in the last 3 years has been like we are standing on the edge of the ocean in the dark. We're waiting for the wave to hit, and we have no idea when it'll be or how high the wave is going to be. And I think that's what we see every time we see a little uptick in COVID cases within the hospital or the office. We kind of get a hold on, because we have no idea what it's going to look like or what it's going to be. We have lived history for the last 3 years. So we have something to tell our children and our children's children. We are the ones that lived through COVID. In early 1900s, it was a flu pandemic and things like that. And we have family members that have talked about those. But we, in fact, have lived history, and our kids have lived history. So we're in a very, very interesting part of life and part of time. So what do? Let's talk about that. There are necessities for well-being, necessities to negate or control burnout. And some of those things are connection and community. I think it's vitally important that I talked earlier about being mentored and about finding your people and other nurse practitioners. But we need connection and community. Maybe we don't need just as much connection and community in the employment area or as nurse practitioners, but we also need it in our social life and in our other life, right? So whether you're involved in a spiritual or a religious group, whether you're involved in some type of hobby that gets you some type of connection or community, all of those things are very positive and are a necessity for well-being. So think about your connections, think about your community. A challenge network to push you to work harder, some self-compassion. And I say a lot and talk a lot about giving yourself grace. And I would tell you that if you're feeling burned out, if you're feeling non-resilient, you need to give yourself grace. Think about all the good work you've done and all the good work you're doing and you're going to do, but you need some self-compassion. A growth mindset. Where do we go from here? Nobody really plans to get into a job and stay for 40 years and do nothing different than what they've done. You might be employed by a big hospital system or a healthcare system, and you plan to maybe move around or up and do something different, but you really need a growth mindset. When you do not have any type of growth mindset, then you become stagnant. You need boundaries. Yes, you'll do it. No, and no is an okay word. You need self-awareness and self-empowerment. So a lot of these things are vitally important for you to necessitate your good well-being. So let's look at approaches. Your individual approach, building the connection. We talked about self-awareness, all the things we just talked about. That's your individual approach. Those are your marching orders. Those are the things you need to do. Now, what about workplace approaches? What do we do if you're in leadership or if you're on committees or ways to begin to culture this and to advocate for this and to provide this environment? We need to empower leadership. Every single nurse practitioner, I'm in the corporate world again of hiring our providers and our staff. I want to empower leadership. I do not want to hire one more person that's just going to do the job. I want them to see themselves as a leader, and I want them to see themselves with a growth mindset of what they want to do next. Now, am I looking for them to leave me very quickly? No, I need them to stay around. But I want to think about ways that we can empower leadership within our offices, within our structure, within our system. We need to empower each and every person that we hire as leaders. Transparency and over communication. This is probably one of our biggest hurdles is not communicating enough. I think so often we think everybody knows what's going on, or we've talked to this one or talked to that one, but we have to be careful. And it's really recommended now, if you're in leadership, that you're transparent to what's going on and you over communicate. I am very quick with providers or whomever I'm leading to sit down at a table and say, tell me what's going on, good or bad. But then we're not going to just have kind of a gripe fest, right? But then how do we fix it? And how do we move forward? And how do we make it better? So transparent. Yep, things aren't great here. How do we make it better? And then over communicating, talking more and more often than we think we need to do. We need to over communicate. That's where we fail to do that for you as an individual. Building community, we'll talk about in a moment. Learning culture, adaptive leadership. We need to adapt how we lead our providers. We need to adapt how we lead our employees. And again, we cannot do just status quo. And then finally, calibrating workload. Interestingly enough, within our palliative program for our big hospital system, I just created the opportunity for all of my NPs to do 4 10-hour days. So we were doing 5 8-hour days, which is a lot. It's also a lot to attract amazing experience when you're doing that, because we know nurse practitioners have options for jobs. So I created the 4 10-hour day work week. I've provided my nurse practitioners 52 extra days off a year, which they are thrilled about. And you know what? It has changed a lot. Their work has increased. Their experience has increased. They are grateful for what they do. They are doing amazing work, and it's helped. Now, what I'm working on currently is working for our physicians and doing something for them to really enhance this and maybe calibrating their workload. So we have to adapt our leadership for the time and where we are and what's going on. It can't just always be status quo. We can't just always do it the way we've always done it. Let's think about being intentional in the workplace. We really need to think about relationship. And again, we must be intentional now. This says no water cooler moments. And I'll tell you what it means. This was a lot. This occurred a lot, and it's occurred more as we have more people doing telehealth. We have, a lot of people that did not return back into practice like they did before. Water cooler moments mean we would get to the office, we'd get our coffee, we would all stand around and talk. We would talk about the game last night. We'd talk about a show we all watched. We'd laugh. That was really, that helped with burnout. That helped with resiliency. But we don't have water cooler moments as much. So we need to be intentional on checking in with our employees and each other. Forget if you're not in leadership. Check on each other. Check on your leadership. We don't mind. Know that this isn't fluff. And I will tell you, I am guilty of this because I, for many years, didn't think much about resiliency. I didn't think much about work, burnout. I love to work and I worked hard and I never thought much about it. But over the last 3 to 4 years, resiliency, what burnout really was, my burnout myself became very apparent. And I learned that this wasn't fluff. It wasn't a joke. It wasn't just, a call word. But isolation is really contributing to our loss of well-being. Do not isolate. So how do you do this? And how do you find your own way to lead here? Virtual happy hour, game night, dad joke of the day. We've started something in our program because we meet a couple of times a week to go over patients. And on Fridays, we do a movie quote. We start with movie quotes, and we might have like a Christmas movie quotes or a certain era or a certain genre. I'm terrible at them. Some of our providers are amazing at them. They've been so fun just to do something silly like that. And I know you kind of think, I don't have time for that, but just something, just to create some type of camaraderie with each other, with administration, with your providers. Do something, find your own way to lead here. Know this, that you are every day doing emotionally powerful work. Whether you think you are or not, you are. Whether you're administration, whether you're in the exam room, whether you're in the hospital room, whether you're in telehealth, you are doing emotionally powerful work, and we need you, and we need you to stay. So a couple of things that people begin to do when they begin to burn out is to do a couple of things. Number one, wall it off. Don't get involved emotionally. You'll be fine. So just wall it off. Now, there can be some safety to that walling off, but walling off doesn't mean it is more of a negative connotation. And I'll explain it in a minute. The second is kind of giving and giving, just putting your head down. Patients are vulnerable. Suffering is unimaginable. I just got to keep working, right? Now, the third one is probably much more appropriate, much more safe. The first two really are kind of negative ways that you can begin to try and care for your patients, but it's probably not going to last. But channeling, I call this parachuting in. And this is what I teach, especially in palliative medicine. We're doing very hard work. We're coming in to a room and we are having very hard conversations of giving, X, Y, and Z options at this point of where we're at. So channeling, being fully present when you're in the room, but when you cross the threshold of the room, when you cross the threshold of the hospital, go outside and you leave to go home, you leave it there. And I would tell you, channeling is probably the best gift you can give yourself. It is very difficult sometimes to not take problems home from the hospital or not take patient issues or patients' emotions home with you. But I think it's very important that we learn to be very fully present when you're in the room. And then when you leave, you leave. And I call it, again, parachuting in, and then you'll parachute back out of the room and you are going to leave. And again, go to the next patient, because each and every patient has a need. Each and every patient oftentimes has an emergency that you are hugely involved in. So just to be clear, the first two that I mentioned, walling it off and giving, are not viable long-term approaches, but channeling absolutely is. And we could talk more about that. I love that idea. But yes, being fully present. I'm going to be fully present. I'm going to sit with you in your grief. I'm going to talk about all of these options. But then when I leave that room, I have to leave those issues there. And again, go see my family, go see the next patient, do what I need to do. Finding rest in the middle of things. I love this book. It's called Wintering: The Power of Rest and Retreat in Difficult Times. We're coming into winter, and a lot of people really don't like it. We have seasonal depression and things along that line, but wintering can be a really positive thing. And it can be a time, I've always found it interesting. And I've always talked a little bit about, a lot of people say they hate winter, they hate time change. I'm quite the opposite. And I remember thinking, maybe I've got the problem, but I think I've found that I find winter and time change and it getting dark early. And I don't love going home in the dark every day, but I find that it gives me the opportunity to rest. You have all the room, if it's light until 8 o'clock at night, you think I probably should get out and exercise and do, and I'm not saying don't exercise, but I find that winter and during the holidays is just the best time to begin to rest and retreat. And really that kind of fills me back up. So resting in the middle of things, you need intentional phase out of the surge and be intentional about it. Like we talked about that water cooler moment. You need to be intentional about resting. You need to be intentional about giving yourself a rest. And here's a way, paying attention to where you can have just very minute times of rest. What about the ride in the elevator? The door is closed and you have just a minute to take a very deep breath. I am the worst to grab my phone and I'll be looking on it as I'm, riding up the elevator or looking at something. Sometimes I can find social media to be it actually can be my way out and a little bit of wintering for a moment, just because I think about something else. I look and see pictures of my girls or whatever. But that can be just a minute that I'm kind of coming out of what I'm working in, and then I'll jump right back into it. So the elevator moment, or dropping into my coffee, taking a moment early in the morning. I'm a coffee drinker. So just taking in a moment to kind of enjoy your coffee, think about your coffee, and breathe. Change of scenery, go outside. We have the capabilities in our hospital system to literally walk in and out of buildings and never walk outside. We can go underneath, between buildings. And that is not good. It's great to be able to rush back and forth, but in all reality, change of scenery, go outside, just to give yourself a breath, breathe a minute, move a meeting outside if you can, do something to get yourself outside and just breathe a second. In turn, provide yourself an intentional permission to winter for a bit. Just like I said, take some time just to rest and retreat and exercise, meditation, and go on vacation. The one thing COVID did for us was provided a whole lot of PTO because none of us were able to take time off during that time. So really having that vacation and taking the time to take time to get away is vitally important. We need to make that available. 3-star strategies to resiliency. A book that really is a great one is Resilient Grieving: How to Find Your Way Through a Devastating Loss. And I want to take a minute and just touch here. In some way or another, we've all had a devastating loss, a loss of a loved one, a loss of a spouse, a loss of a marriage, a loss of a job. Think of things you've lost, a loss of community at times. We've all experienced devastating loss. We just have. It's been hard. So I want to introduce you just to a minute and talk just a few minutes as I'm wrapping things up about Lucy Hone. Dr. Lucy Hone is Australian, and she began her PhD work on resiliency during a big flu pandemic in Australia a few years back. And it was very difficult. She actually traveled internationally. She kind of came home and began to work with patients and work through kind of what was going on in Australia at the time. And she thought, as she was writing her PhD dissertation, that this was the resiliency of grieving that she was going to live through, and kind of this was what it was going to be. In fact, it wasn't. What happened with Lucy Hone is actually a year after she began writing her PhD dissertation, and in the midst of writing this, they were vacationing with a family friend, and her daughter got in the car with the family friend, and the little girl's best friend, they were 12, got in. They were going on vacation, so they were riding in that car. That car was hit, and all three of them were immediately killed in a horrific wreck. And Lucy Hone then discovered that she was then grieving and really living her PhD work through this horrible, devastating loss. And so she really looked at and defined resiliency, and her definition is the ability to withstand or recover quickly from difficult conditions. Now, I think we can talk about quickly. I don't think we have to push ourselves through difficult conditions. But more than anything, what we do have to do, no matter how devastating it is we have to withstand, and at some point we have to recover, whatever it is. So let's look for a minute. Some things about resiliency, and I love kind of some of these statements. Life doesn't get easier or more forgiving, but we get stronger and we get more resilient. I feel that I am more resilient. The more years I live, the more birthdays I experience. So we get stronger. We find resiliency. Resilience is all about being able to overcome the unexpected. The goal of resilience isn't to just survive, but to thrive. And finally, when we learn how to become resilient, we learn how to embrace the beautifully broad spectrum of the human experience. So this is kind of some lessons from her book and the Circle of Resilience. Really, the idea is, if we are resilient, then we are going to lessen burnout. So how can we do this? Reflection on our own values, self-care, taking care of ourselves, seeking professional care. I'm grateful now that mental health care, counseling, all of those things are not bad words as they were for many years. But it's really okay for every single person out there to seek professional care and be able to talk through life coaching, counseling, ways to talk through to prevent burnout, but to keep us resilient. And finally, mobilizing resources both inside and out of the workplace. So here's some perspective from Lucy Hone. She said, know this: suffering is a part of life. You want to say that it's not. You want to say that, maybe some of us are just going to avoid it. But at some point, every single one of us will experience suffering, loss, devastation, because we are human. So just know suffering is a part of our life. Now, one thing she learned through that grieving process and through becoming resilient was to carefully choose where you're directing your attention. And kind of to ask yourself, Is the action or thought helping me or harming me? I think as women, and I think as we get older, it's real easy. I don't know if you've seen the meme, but it says something like, I told my family, thank you very much for keeping me up all night worrying about things that haven't even happened. We are bad about that. Like, we can ruminate in some of this issue, and it's easy to just think about all the bad things that can possibly happen. So carefully choose where you're directing attention. And this was one of the examples she gave. She said she wasn't sleeping well early in the midst of everything that happened with her daughter. So she would wake up in the middle of the night and she'd get pictures, and she'd pull out pictures and she'd begin to look through them. And sometimes it was helpful, but she said during the night she found that it was not helpful, but it just caused more grief and caused more harm. And it really was harming to her. So she would ask herself, as she would begin whatever task it was she was going through the grief process, is the action or the thought helping me or harming me? And she said, and sometimes there were times when she would sit down and look at pictures, it was very helpful to look at a time, an event, whatever it was, but also there were times when it was very harmful. And she would call that, and she would call it, and then she would stop doing it. So it's important to be self-actualization. Like, is this really going to help me, or is it going to harm me? And that really helped a lot. And then she finally asked herself and how she made it through and how she became resilient. Well, she said, where do you find your joy? So I want you to take a minute and think where you actually find your joy. Because we all need to find our own joy, whatever it is, and everybody's joy is different. And I'll share with you, this is my joy. These are my kids. I have two girls. The other two are marrying, and one's married in, and we have a new grandbaby, which is not pictured here. The other one's marrying in. Then my husband. We have dogs. We have about 10 acres. We bought our 10 acres during COVID, which has been the biggest blessing of our life, just to be able to sit and enjoy and kind of winter at times. So, this may not be your joy, but find your joy and think about your joy. Create a little thing for your computer of where you find your joy. I challenge you to do that. So think about where you find your joy. This is just where I find mine. And finally, I want you to know that success is not final. Failure is not fatal. And it's the courage to continue that truly counts. So just to summarize things, there's a shortage, and there's going to be a shortage of 3.2 million healthcare workers by 2026. So we need you. We need you to remain resilient. We need to fix burnout if you're burned out. We need you to prevent burnout if you're thinking you're getting there. You are in demand, and we need you to do what you want to do. Thank you again for what you do. And know that we need to work at a state level, talk more about scope of practice so that we are able to take care of the patients that are lacking access, and we are able to practice to the full extent of our education and full practice as nurse practitioners. Burnout, chronic workplace stress, it occurs. There's a high rate of it currently. I just want you to begin to adopt some healthy coping strategies. Cultivate resilience, take care of yourself, take care of others, build connections, and consider professional care. Many of our hospitals provide it. Many of our systems provide free professional care. Utilize it, step into it, and because we need you on the front lines. I want to thank you again for what you are doing. All right. That's the end of our first session. So I want to take just a minute and do our question and answer, that post-test we talked about earlier. So here's some post-test polling questions, and here is question number 1. What is the estimated shortage of U.S. healthcare workers expected by 2026? Up to 2.5 million, up to 3.2 million, up to 4.1 million, or up to 4.7 million? Answer now. You got it. You guys are smart. You knew it before, and now you know it for sure now. So you got it. It's 3.2 million. We have work to do. How many states in the U.S. have full practice Authority for nurse practitioners, 19 in DC, 27 in DC, 33 in DC, or all 50 states and DC. '27 in DC, you got it. The results of a 2022 survey indicate that the current level of burnout compared to that during COVID-19 quarantine among majority of NPs was lower, similar, or higher. Higher, absolutely. And finally, the Veterans Affairs Circle of Resilience includes self-care, seeking professional care, and which of the following? Calibrating the workload, adopting a growth mindset, setting healthy boundaries, or reflecting on values. Everybody said setting healthy boundaries, not wrong. Correct answer though here is reflecting on values, but healthy boundaries, absolutely. But reflecting on values, what are your values? So very good. So thank you so much. I'm looking at questions very quickly. Oh, great question. Okay. So I have somebody asking about the map of full practice authority map. And it said, what are the differences between red and yellow states? That's great. Red states are states that require physician supervision. Yellow states require collaboration. So think of red states as more stringent oversight. That's why it's red. And yellow as not full practice authority, but less oversight, but still with oversight. So it's really just kind of levels. And then green, of course, is full practice authority. Good question. Thank you. I should have talked about that. There's a question about, isn't it true that even if you have full practice authority in your state, you must have a CPA with an MD to bill Medicare? Not in every state. That may be state mandated, so not in every state. There's a question about our presentations being available to review later. Yes, you guys will have access to our presentations in the next few days and weeks. Another question says, I've been a CNP for 28 years. Thank you very much. I own and ran my independent family practice clinic for 15 years. Due to the pandemic, I was forced to close, become an employee of one of the large healthcare forces here in South Dakota. Now I am forced to have a supervising physician who has been born during my NP career. So there's more to be done here, even though we have full practice authority. Yes, yes, yes. That's the one thing to know. Our job does not end the day our state gets full practice authority. That is where the job begins. And we have to, one, continue to fight and maintain full practice authority. But you're exactly right. Number one, thank you for working for 28 years. And I'm so sorry about your practice. But yes, we will have to maintain and we have to continue to work with our legislators to make certain that we don't have this type of oversight, because they can still have some oversight even if you have full practice authority. So yes, you're right. Your full practice authority does not just, we don't go to sleep. We don't just stop just because we get it. There's still work to be done. Thank you for what you're doing. And finally, or two more very quickly, and then we'll go to our next presentation. Any recommendations on leaving when you leave? When your employer has utilized technology to better serve the patient, rendering providers on call for themselves 24/7 to our personal devices. You know, at the end of the day, I think that's a conversation with employees and employers of saying, okay, fine, but what is still that requirement? there's got to be some downtime. And I think that's a conversation of what it really looks like. And yes, it's not perfect. I can't tell you exactly what it looks like, but I think it's a conversation with your employer and with other providers. What are they doing? Because you've got to have some downtime. You've got to leave when you leave. Some of these situations, I'm always available by email. I'm kind of the same way. I do that often too, but you know, it's not perfect. I would find out what your other NPs are doing in your practice. Also talk with leadership about what the true recommendations are. Like, is it check it twice a night, or is it to check it, twice on the weekends? But not to be connected to it 24/7. And if it is being asked to do that, then there probably needs to be compensation. That's a whole nother story. Finally, I was asked about the books that I mentioned. One is called Wintering: The Power of Rest and Retreat in Difficult Times. And that's by Catherine May. The other book is Resilient Grieving by Dr. Lucy Hone, Hone. All right. So thank you guys so very much. I hope you've enjoyed kind of our first hour. And really, I hope you leave a little more refreshed. And I hope that continuing education can be refreshing. So without further ado, let's move into our next speaker. I believe we have Martha. Martha, are you with me?
I am. Can you see me and hear me okay?
I can see you. Hey, Martha. This is Dr. Martha Kingman, and we are going, and by the way, guys, just to let you know, if you need to pull away and get a quick drink or whatever, don't be gone long. No, your questions are getting ready to be, your pretest questions will be pushed in just a minute. So step away briefly if you must, but hurry back. And without further ado, I'll introduce Martha Kingman as our next speaker. She is a family nurse practitioner working in the Pulmonary Hypertension Comprehensive Care Center at the University of Texas Southwestern Medical Center in Dallas since 2000. She earned a doctorate in nursing practice from Texas Christian University in 2011, serves on various pulmonary hypertension advisory boards and steering committees. She speaks at local, national, and international conferences. She's a sub-investigator on several ongoing pulmonary hypertension clinical trials, an active member of PH Professional Network, a past chair of the Symposium Planning Committee. Martha has co-authored numerous pulmonary hypertension publications and served on the editorial board of the Advances of Pulmonary Hypertension Journal. Her main area of interest involves the management of prostacyclin therapies. And I'm going to tell you, pulmonary hypertension has been an area, I have a lot of patients with it, but has always been kind of an area that I didn't know as much as I felt I should. And I will tell you, Dr. Kingman is our expert. So she is going to spend the next hour or so talking about management, assessing, diagnosing, and managing pulmonary arterial hypertension. So take it away, Dr. Kingman.
Oh, thank you for the introduction.
Yes.
Okay, we'll go ahead and get started here. Sometimes I have trouble advancing these slides. Okay, here we go. I've already been introduced, so we'll skip that. These are my disclosures. And these are our learning objectives. We're going to talk about signs, symptoms, and risks for pulmonary arterial hypertension. You may hear me say PAH for short. We'll talk about patients who would benefit from referral to an expert center, which is highly recommended. And we'll talk about treatment plans, some of the current therapies that we use, and some of the emerging therapies that are on the horizon, some of which are very exciting. So we'll start with these pre-test polling questions, see where everyone is at. PAH definitions and disease toll. What is PAH? Who gets it? And how does it affect them? Oh, I think you already did the polling questions. I apologize. Okay, so pulmonary arterial hypertension is a rare disease. Pulmonary hypertension is a global term, and there are multiple different types, which we'll talk about. But PAH specifically is very rare. It only affects about 1% of the global population, and we only have 500 to 1,000 new cases annually in the United States. About half of the cases are what we call idiopathic. That means, of course, that we don't know what's causing them. Interestingly, PAH is much more common in women than men. About 80% of our patients are women. We're not really sure why that is. Sometimes we wonder if estrogen plays a role, but that's not been confirmed. This used to be a disease of younger women. And over these last couple of decades, we are seeing older patients, and certainly any age person can get pulmonary hypertension. Even there's a newborn form as well, which we're not going to discuss today. But the point here is that this disease of PAH is very rare. Now, we define pulmonary arterial hypertension by doing a right heart catheterization. That's the only way we can diagnose the disease. And just to give you a really quick, brief pathophysiology, what happens in pulmonary arterial hypertension is that the pulmonary arteries, and those take the blood, of course, from the right ventricle over to the lungs to get oxygenated, become narrowed, constricted. The vessels are hypertrophied. This decreases the lumen, and then the right ventricle has to pump harder to get the blood over to the lungs. It eventually can't handle the workload, and patients will ultimately pass away from right heart failure. Now, the two boxes here, the box on the left shows the historic or the old definition of pulmonary arterial hypertension that was in place from the 70s until 2018. And since 2018, we now use the definition on the right. And that is on right heart cath, you have to have a mean pulmonary artery pressure over 20 millimeters mercury. If you look on the left side, you can see we used to say 25. So this has been lowered so that we can diagnose more patients, hopefully earlier. And then the pulmonary vascular resistance has also been lowered from 3 to needs to be greater than 2 Wood units. And then the pulmonary artery wedge pressure, which is the left-sided heart pressure, still does need to be below or equal to 15. So in order to have PAH, you have to have a mean PA over 20, a PVR over 2, and a pulmonary artery wedge pressure 15 or less. This just illustrates a little bit what happens inside these pulmonary arteries. And on the left, you can see that the vessel walls start to become thickened. There's several layers, the medial layer, the intimal layer, the smooth muscle layer. They all become thicker, or there's pro-proliferative properties there. And there's some small blood clots that form within these blood vessels. We got some small thrombosis. And if you look in the middle, you can see the lumen normally wide open, and then you get this narrowing of the lumen. And on the right shows you that the right side of the heart starts to enlarge. This is how it looks on echocardiogram on a static picture. On the left, you have a normal echo. And if you're not familiar with echocardiograms, just quickly, they're upside down and backwards. Kind of get used to that. So on the top of these pictures are the ventricles. So you can see on the right in pulmonary hypertension how this right ventricle becomes so much larger. And oftentimes the septum between the right ventricle and the left ventricle starts to push over into the left ventricle and kind of smushes it. Not a very good medical term, I guess, smush, but pancake LV. And when that happens, that's late in the disease. Sometimes we'll even see a reduction of the LVEF from this compression from the big right ventricle. This slide, it looks busy, but it's probably the most important slide to show you and to make sure that is clear. Is this term of pulmonary hypertension is an umbrella term. There are 5 different types, and they're listed here. And we call these groups or WHO groups. The World Health Organization years ago was involved in this classification, and we still kind of call them WHO groups, or sometimes we just say group. So there's group 1, group 2, 3, 4, and 5. Group 1 PH, pulmonary hypertension, is what the focus of this talk is about, pulmonary arterial hypertension. You can see in the box there, the idiopathic forms that I mentioned, and there's also associated types. And then group 2 pulmonary hypertension is a form of pulmonary hypertension that occurs from left heart disease, and it is very common. For every 10 patients that we see in our practice in our pulmonary hypertension clinic, 8 out of 10 of them will end up having group 2. So if you have a lot of pulmonary hypertension patients, chances are a lot of those are group 2 patients. Group 3 pulmonary hypertension is a form of pulmonary hypertension that occurs because of hypoxic lung disease. In hypoxic states, the pulmonary arteries constrict, and make the pressure go up. So that's pulmonary hypertension. And the treatment for group 3 pulmonary hypertension patients is good oxygenation. These are usually patients who have advanced interstitial lung disease or advanced COPD. We do have one drug that is approved for group 3 just fairly recently. Group 4 pulmonary hypertension is called CTEPH, which is chronic thromboembolic pulmonary hypertension. In this form of pulmonary hypertension, rather than narrowed pulmonary arteries, you have pulmonary arteries that are blocked by chronic blood clots. So those are patients who've had pulmonary emboli that don't resolve and become chronic. This is very rare. Only about 4% of people who have a PE go on to develop CTEPH. In order to have CTEPH, you have to have pulmonary hypertension on the heart cath, and you have to have blockages on VQ scan. And then group 5 pulmonary hypertension is this bucket where we put all the patients that we know, or the conditions that we know can cause pulmonary hypertension, but they haven't been well studied. These patients haven't been enrolled in clinical trials, and we don't have any guidelines for them. So they're sort of in this holding area until further research is available. Examples there would be sickle cell disease, end-stage renal disease, sarcoidosis. Those things we all know can cause pulmonary hypertension, but we don't have recommendations yet, so we put them in group 5. So taking a little bit deeper look at group 1, PAH, again, half of them are idiopathic. There's a small group, which is listed here as 1.2, which is heritable. The gene mutation most commonly that we see is the BMPR2 mutation. And when we do see this in families, it tends to be multiple family members that have passed away from pulmonary arterial hypertension. The next category, 1.3, is associated with drugs and toxins. And back in the early 2000s, when I started in this career, the drug and toxin that we were seeing was the drug fen-phen, which was a diet drug that people took for weight loss and was taken off the market because it caused pulmonary hypertension and also valvular heart disease. But now what we see in this category is methamphetamine use. Methamphetamine is our fastest growing group of group 1 PAH patients. We're seeing more and more of these patients that are using meth and getting this disease. And the 1.4 are the associated with, meaning they're associated with another condition. And within this associated group, connective tissue disease is the most common. And within connective tissue disease, the most common is scleroderma. Scleroderma patients have about a 30% chance of developing PAH. So we do see a lot of scleroderma patients, but also lupus, mixed connective tissue disease, rheumatoid arthritis can also cause PAH. HIV is a known cause. Portal hypertension, liver disease, patients who go on to develop what we call portal pulmonary hypertension are in this group. Congenital heart diseases can cause pulmonary arterial hypertension, and then schistosomiasis, there is a infection that occurs most often in Africa, Asia, and Brazil. I've only seen it one time in 24 years. And then pulmonary veno-occlusive disease, a very, very rare form, and then the newborn form is also in group 1. Unfortunately, the prognosis for patients with PAH is not very good. In the 1980s, the National Institute of Health collected survival data, and that was before we had any treatment. So we know if patients are not treated, their average survival is 2.8 years. Now we have 14 medications that we use to treat pulmonary hypertension. Our survival is still only at 5 years. So it's improved, but we still have a long way to go. The nurse practitioner, like myself, has a lot of roles in the treatment of and management of pulmonary arterial hypertension, and more PH centers are utilizing advanced practice providers. We do really everything. We see the new patients, the follow-up patients, we order the testing, we review the testing. We help with managing side effects of medications, doing titration. Some of our medications have to be titrated. There is a lot of work to be done for sure. Okay, so we'll go on to this interactive patient case study. This is Rochelle. She's an African-American woman, age 32. She presents to you with progressive shortness of breath over the last 4 months. She also feels lightheaded when she climbs the stairs. She has unusual fatigue during the day, just feels tired all the time. She didn't have any chest pain, syncope, or palpitations, and she was diagnosed with scleroderma 9 months ago. Other than the presence of shortness of breath, what is the biggest clue that Rachel may have PAH? The duration of the dyspnea, being female in the right age group, experiencing unusual fatigue, or the fact that she has scleroderma. Okay, let's see where we are here. Oh, excellent. Okay, I guess I'm not supposed to tell you that. That was good. Find out later. Okay. All clues should have raised the suspicion for pulmonary arterial hypertension, but as the majority of you answered, the patient has scleroderma, and that's a red flag for PAH. The duration of the dyspnea, sometimes we see patients who progress really fast. Like they were fine a few weeks ago and now they're very short of breath. And then we have patients who have progressed over a 2 or 3 year period of time. So it does vary quite a bit. She was in the right age and gender, but really that wasn't the strongest indicator to suspect PAH. And neither was fatigue. How long does it take on average for a patient to receive an accurate diagnosis of PAH? 9 months, 18 months, first presents to a provider with shortness of breath until they get diagnosed averages about 34 months. And this data is a little bit old, it's revealed data, but more recent data shows that we really haven't made a lot of progress here either. And that's primarily because this is a disease that can be very vague, and the symptoms can be insidious, and it's so rare that it's not often thought of as the first thing when a patient sees a provider. Okay, so we're going to move on to talk about how we diagnose pulmonary arterial hypertension. The symptoms are listed here in order of early symptoms and then late symptoms. Dyspnea on exertion is by far the most common symptom of pulmonary arterial hypertension. Most patients at rest are not short of breath, but when they get up to exert, then they start feeling short of breath. Fatigue is very common. Our patients will tell you they're tired all the time. This shortness of breath bending over or lightheadedness bending over is really common. Some patients experience palpitations or chest pain too. Hemoptysis is listed here. It's not very common. I've seen it maybe 10 times. And I also haven't seen too much abdominal pain, which is listed here from this database. Weight gain from fluid retention, certainly very common. Lower extremity edema. And then syncope is listed there at the end, and syncope is a very late sign. It tells us that the patient has a drop in their cardiac output. It's a big red flag that the patients are not doing well. We talked about the WHO group classification scheme. This is the functional classification, and it's another way we classify patients, and it's just a description of how short of breath or how symptomatic they are. If you're familiar with heart failure functional class, it's the same thing. So functional class 1 patients have no symptoms. Functional class 2 patients can do their normal activities, but if they try to exercise or climb more than 2 flights of stairs, they'll be symptomatic. Functional class 3 patients are short of breath with normal activities around the house. They're ADLs, 1 flight of stairs. This is where most of our patients fall, is functional class 3. And then functional class 4 are the sickest patients. They may be having syncope, as we mentioned. They've got right heart failure, so they have lower extremity edema. Sometimes they can even be short of breath at rest. It's the end stage patients. So the diagnostic algorithm for pulmonary arterial hypertension was updated last year in 2022 by the ERS-ESC, that's the European Society of Cardiology and the European Respiratory Society. We do follow those guidelines in the United States. And the diagnostic algorithm starts by a patient presenting with shortness of breath to a healthcare provider, usually a primary care provider is the first one. And if that primary care provider suspects that the patient might have PAH, maybe they're very educated and have a scleroderma patient in front of them, whatever, then they would directly refer to the pulmonary hypertension center. Usually that's not the case, and some testing is done first. This is the diagnostic algorithm. So at the top, you can see the general practitioner sees the patient first, does a good history and physical, maybe does an NT-proBNP and oxygen saturation, EKG. And then the algorithm splits based on whether that healthcare provider suspects that it's a lung disease problem or if it's a pulmonary hypertension / cardiac problem. So if they suspect a lung problem, they would go down the algorithm on the left where it says lung disease and do these lung assessments, which might include pulmonary function testing, high-res CT, chest x-ray maybe. And then if they identify a cause, great. If they don't, they need further workup. If that general practitioner suspects that it may be a pulmonary hypertension or cardiac issue, but not worried enough to directly refer to the PH center, then they would do some additional testing. And the most important one there is the echocardiogram. If pulmonary hypertension is suspected, patients need to have an echocardiogram because that's where we can really start to see signs that the patient might have pulmonary hypertension. And then based on those echocardiogram findings, if it looks like there's a probability for pulmonary hypertension, then the patient is referred to the pulmonary hypertension center for the right heart catheterization. In the pulmonary hypertension center, we do a lot of different things, some of which are listed here. We will complete the workup and do the right heart catheterization. We're involved in a lot of clinical trials, research things. We have patient support groups. We have a huge multidisciplinary team made up of medical assistants. We have 5 nurses. We have 6 advanced practice providers, 8 physicians. So it's a big multidisciplinary team. And what we do, and I think most places, is regular meetings about difficult patients where we all get together. So lots of specialized things that we do in the pulmonary hypertension center. Now, when a patient comes to us and we're trying to figure out why they might have pulmonary hypertension, we do the labs that are listed here. We do those to look for connective tissue diseases or autoimmune diseases to see if that might be what's causing it. We check everybody for HIV, and we check hepatitis serologies too, to see if we may be looking at a liver disease patient. And then we generally will do pulmonary function tests on all the patients to see if they have an obstructive or a restrictive lung disease, because that would make us think more about group 3 pulmonary hypertension. This one listed here, this VQ scan, is super important. That's gold standard test for all patients with pulmonary hypertension, because it's the test that can identify CTEPH patients who have chronic blood clots in the lungs. So all patients get a VQ scan. Now, the way that we evaluate our patients over time is by doing a process called risk assessment. And there are multiple risk assessment tools available. What's shown here is the REVEAL and REVEAL Lite risk assessment tools. And these are derived from a United States database, the REVEAL database. There's others that were developed from European databases. I'll just focus on the REVEAL Lite because it's the one that most people are using. It's the one we use. It's an abridged or a shorter version of the full REVEAL calculator, so it's a little bit easier. But we can use this calculator to determine if patients are low, intermediate, or high risk for death in the next 12 months. And the things that we look at in Reveal Light calculator, Reveal Light 2.0, is their functional class, the systolic blood pressure and heart rate, their 6-minute walk distance, the NT-proBNP or the BNP, and then their renal function. All of those things are associated with these patients, their prognosis. Now, this is the European approach, the ERS-ESC risk assessment tool. And if you look on the left, it has the determinants that are looked at in this approach: clinical signs of right heart failure, progression of symptoms, are they having syncope, what's their functional class? And you go through all these determinants on the left, and you go over to the chart on the right, and you see where they fall. So for example, if you look halfway down, 6-minute walk distance. If they are walking 200 meters on their 6-minute walk test, they would fall in the intermediate risk category. So you just go through all of these, put little check marks, and see where the patients fall. Sometimes they'll fall in kind of a little bit in both, a couple of different categories. You kind of have to look at where most indicators fall, and then to determine if they're low, intermediate, or high risk. That's the 3-strata model, and that's what's used at the time of diagnosis. So then the Europeans have this 4-strata model that is used for follow-up. And what they did here is they took the intermediate group and they split it in half into intermediate low and intermediate high. And that's because they were finding that 70% of patients fell in the intermediate, but it was a wide range. And a lot of patients were doing a lot better than others. And so it made sense to split that intermediate group. So now we have low risk, intermediate low, intermediate high, and high risk. And then there's only on the left, only 4 things that we look at, or 3 things that we look at here: functional class, walk distance, and NT-proBNP or BNP. And again, you just plug in whatever variable they fit into. This is their guideline for how often testing is repeated. And I will tell you, in pulmonary hypertension centers, a lot of people do things differently. We all have our approach, but certainly at baseline, all of these tests are done, and a right heart cath especially. And then for instance, if you look halfway down the echocardiogram, they're recommending that every 6 to 12 months, or if therapy's changed, every 3 to 6 months. In general, I would say that our patients get an echo every 6 months, and they get a right heart cath, usually always at diagnosis, and then usually 3 months after we make a therapy change to assess how that's going. And then we do risk assessment every 3 months. No matter what risk assessment tool is being used, they're all going to be comprised of these parameters listed here. They're all going to have some biochemical marker. It could be an NT-proBNP or BNP. They're all going to have some measure of clinical assessment, whether that's functional class or progression of symptoms, signs of right heart failure. They'll all have some measure of exercise capacity. Usually that's the 6-minute walk test. And they'll all have some echocardiographic parameters, right atrial pressure and the presence, right atrial size, and the presence of a pericardial effusion correlate with survival. And then on hemodynamics, cardiac index, right atrial pressure, and mixed venous sat all correlate with survival. So you will see those things in the various risk assessment tools. Okay, so we're going to move on to treatments. This shows the goals of our therapy, and certainly we want to improve hemodynamics, which is listed first on the left. And it's very important to the providers, but not very important to patients. They just want to feel better. They want their activity tolerance to improve. They want to have less symptoms, improve their quality of life. We try to decrease the clinical worsening events, or extend the time to a clinical worsening event, and in the long run, hopefully improve survival, and hopefully continue to improve survival. But as far as risk assessment, our overall goal is to get all patients to a low risk status. They, again, better exercise capacity, improve their quality of life. We want to improve their right ventricular function and size, and then hopefully improve their mortality. Now, the treatment for pulmonary arterial hypertension is divided into these 3 pathways. There's 3 different pathways that our medicines target to treat patients with PAH. The first one on the left is the nitric oxide into the mechanism of action too much here, other than to say that within this pathway, we have vasodilators that include PDE5 inhibitors, such as sildenafil and tadalafil, that you may more commonly recognize those as being used for erectile dysfunction, but we use those in PAH. And also the soluble guanylate cyclase stimulator, riociguat, falls in the nitric oxide pathway. And nitric oxide is a vasodilator. It just opens up the pulmonary arteries. Now, the middle column there, if you will, is the endothelin pathway. Endothelin is a molecule that we all have that causes our blood vessels to constrict. So we use medications called endothelin receptor antagonists, or ERAs, to attach to the endothelin receptors on the pulmonary artery walls to block the ability of the pulmonary arteries to constrict. There's 3 drugs in that category. We'll talk a little bit more about them in a minute. We always will only pick one drug per pathway. So it can be on one nitric oxide pathway medicine, one ERA, and then the prostacyclin pathway on the right is where our most potent drugs are. The prostacyclins are very potent vasodilators. They are felt to potentially have some anti-proliferative properties as well. They do have the most side effects that we'll talk about. If someone was on triple therapy, they would be on a drug from the nitric oxide pathway, an ERA, and some form of prostacyclin. This table shows the medications that are approved by the FDA in each of these categories. So the top line are the ERAs. Ambrisentan, bosentan, and macitentan are the names of those. Bosentan was the first one approved by the FDA. That was in 2001. And it has a black box warning for liver injury. So if you're treating a patient with bosentan, they have to go to the lab every month and have liver function testing done. The ambrisentan and macitentan do not have that risk. The next line is the soluble guanylate cyclase stimulator. There's one, it's called Adempas, is the brand name, of riociguat. The side effects are listed there. The most common concern with it is hypotension. And then it's very important with the PDE5s and the soluble guanylate cyclase stimulator that patients can never take any form of nitroglycerin with any of these drugs because they can cause profound hypotension if used together. Sildenafil and tadalafil, the PDE5 inhibitors, we don't see a lot of side effects really. Sometimes patients will have headache when they first start it, but those drugs tend to be the most well tolerated. And what I should have also said before I move on is the ERAs and the soluble guanylate cyclase stimulator all are known to cause birth defects in women. So any woman of childbearing potential has to have monthly pregnancy testing and 2 methods of birth control, because we know that these drugs in animal studies caused craniofacial deformities. So super important that we make sure that the patients don't get pregnant. And these are the lists of the prostacyclin therapies. You can see there's quite a few. Epoprostenol was the first prostacyclin on the market. It was the first drug that was ever approved for pulmonary hypertension. That was in 1995. And epoprostenol is, that brand at the time was called Flolan, and now we use a brand called Veletri, and that's why they're both listed here. They are continuous IV infusions through a central line catheter 24/7. They have a lot of side effects, and they're listed here: flushing, headache, jaw pain. Patients can get leg pain, body aches, GI side effects that aren't listed in here and should be, nausea, vomiting, diarrhea. Because of these side effects, we start these infusions at low doses and then slowly titrate them up. And then there's iloprost, Ventavis listed on here. That has just recently been taken off the market because the company's not making it anymore. It wasn't that there was a problem with it. But then you see treprostinil, and there's 5 different ways you can give treprostinil. It can be given orally in a drug called Orenitram, and it can be given by continuous IV infusion, like the epoprostenol, and it can also be given by continuous subcutaneous infusion. It can be given by inhalation, a couple different companies making it, and that can be given by a nebulized approach or by a dry powder inhaler. And then the last one there is the prostacyclin receptor agonist, It's called selexipag, and it's a pill. Now, with the prostacyclins, those side effects are pretty similar through all of these prostacyclin drugs. They're more severe in when we use the infusions than the oral therapies in general. And then the inhaled prostacyclins are also less side effects with that than the infusions. Okay, so this is just mentioning this newest form of treprostinil, which is a dry powder inhaler, and that happened just last year. And so this was a pretty big advance because this drug is dosed 4 times a day. It has a relatively short half-life. So if the patients are doing it by nebulization, it can take 10 minutes 4 times a day. But now they have dry powder inhaler, and they just take 1 puff 4 times a day, and they can stick it in their pocket and go about their day. So it has made life a little bit easier for some of these patients. There's some advantages and some drawbacks to inhaled prostacyclins. The advantage primarily is we get the drug right into the lungs where we want it to be, and we don't see as much systemic side effects. So that's helpful. On the disadvantage side, it can be an irritant to the airways, and many patients will cough for a little bit after their treatment. Usually that is not doesn't cause them to come off therapy, but it can be an annoyance. And these drugs, this one mentions that it can be very costly, and I would say that is true of almost all of our medications, actually. We do use these drugs in combination. When a patient's first diagnosed, almost all of them are started on an ERA and a PDE5 together, and then we add a third medication if needed. If they're high risk at the beginning, we'll put them on a drug from all 3 pathways up front. So these new guidelines from last year say newly diagnosed patients who are low or intermediate risk should be started on an ERA and a PDE5 inhibitor. There should be an R on the end of the word inhibito there. That came into place because of a big study called the Ambition trial, where they looked at patients who were on an ERA or a PDE5 alone and compared them to a group that was started on both at the time of diagnosis. And the patients who were started on dual therapy at the time of diagnosis had a much better long-term survival and long-term outcome. So we always start 2 drugs up front. This is that Ambition study that I just mentioned. They looked at the graph here shows the difference in patients who had no worsening events. And they looked at clinical worsening as the primary outcome, and it was out to 192 weeks. So you could see the patients that were on 2 drugs, and what they used was ambrisentan and tadalafil together, and then compared to the patients on the pooled monotherapy. So the blue line had much less clinical worsening events than the patients who were on monotherapy. And that's what that's showing you. So then we learned that 2 drugs were better than 1. So that led to a study called Triton that looked at, well, maybe we should just be putting patients on 3 drugs up front. 2's better than 1, maybe 3's better than 2. And this was surprising to most of us. It was a negative study. They looked at comparing patients on 2 drugs, and they used macitentan and ERA and tadalafil, a PDE5 inhibitor, plus selexipag, which is that oral prostacyclin agonist. So that group got 3 pills, and compared it to patients who just had 2 drugs, macitentan and tadalafil, and then the placebo. And there was no difference in their primary endpoint, which was time to disease progression. So this study was negative. Despite that, though, the guidelines still do call for patients being started on triple therapy if they're very high risk. If they're in right heart failure and doing really poorly, we still do start patients on triple therapy. We just don't do it routinely for everyone. This is the updated treatment guideline from last year, also again from the European guidelines. And it starts with the right heart catheterization. We do a test called a vasoreactivity test during that first right heart cath in some patients. And that just means that we give a potent vasodilator during the right heart cath to see if they have, the pulmonary arteries have the ability to acutely open up or relax, vasodilate. Generally, they do not, and only about 5-10% of cases have that vasoreactivity. The most do not. If they do, if they're in that small group that does have a positive vasoreactive response, then they may be eligible to be treated with calcium channel blockers. But again, that's pretty rare. So back to the treatment algorithm here. The general measures are listed in green, and those include things like oxygen in patients who are hypoxic, diuretics in almost all the patients, pulmonary rehab, pregnancy prevention, those sorts of things. So then the algorithm splits into two sides. On the left, it's patients without cardiopulmonary comorbidities. So that's just a pure group 1 PAH patient who doesn't have anything else going on pulmonary or cardiac wise. On the right-hand side is patients who have cardiopulmonary comorbidities. And if you start on the left, the patients without cardiopulmonary comorbidities, they do the 3-risk strata approach for risk assessment that I showed you, and they determine if they're lower intermediate risk, then they get started on the ERA and the PDE5 that we talked about. If they're high risk, they get started on the ERA, PDE5, and an IV or subcutaneous prostacyclin infusion. Then they have regular follow-up, that's usually 3 months. And then the 4-strata risk assessment tool is used. And at that point, if they're low risk, great, you should continue them on their current therapy. If they're intermediate low, remember this one splits that intermediate group, then you add a prostacyclin, or you could switch their PDE5 to the soluble guanylate cyclase stimulator as an option. If they are intermediate high or high risk at that follow-up risk assessment, then we add IV therapy or sub-Q therapy and consider referring them for lung transplant. Now, if you have a patient who has a cardiac or pulmonary comorbidity, it's where it gets the waters get a little muddy, because we sometimes see patients, or it's not uncommon to see patients who have group 1 PH, but then also might have a little bit of group 2 pulmonary hypertension because they have diastolic heart failure, for instance. In those cases where there is a cardiac or pulmonary comorbidity, the guidelines are to start initial monotherapy in those patients, watch them closely for worsening, and then consider additional therapy, kind of an individualized approach. Okay, so we talked about the current therapies that we have, so we're going to move on and talk about some of the emerging therapies that are on the horizon here. And some of them are listed here. This, the one on the top is a Merck study where they're looking at a soluble guanylate cyclase stimulator by inhalation. The next one is a clinical trial called a DEWI that is already completed, actually, and it is looking at a combination pill of an ERA and a PDE5 inhibitor. And that could potentially be really helpful because instead of taking 3 pills, the patients could potentially just take one combination ERA and PDE5. And the 3 is because tadalafil is 2 pills. So tadalafil and ambrisentan or macitentan would be 3 drugs, so 3 to 1. And then ralinepag is a prostacyclin receptor agonist, similar to selexipag. It's in phase 3 study now, a study called at ralinepag, which may have a longer half-life and a more steady, more stable blood level. The next one there is seralutinib. It's an inhaled PDGFR antagonist. It's being studied by Gossamer. They're getting ready to do their phase 3 study now. Then sotatercept is the one that the PH community is super excited about. To be honest with you, it's finished phase 3. The results were fantastic. It's been submitted to the FDA. The approval is expected end of March. It would be in a new pathway. So this time next year, if I'm asked back, I might be talking to you about 4 pathways instead of 3. But what we're excited about with sotatercept is it may actually reverse some of this remodeling that we see in the pulmonary arteries. Some of that thickening of the vessel wall may actually get to the heart of the disease here rather than just vasodilating, which is what the majority of our drugs do. And Listed here, Xena, Soteria, Hyperion, and Moonbeam are additional studies that Merck is doing with sotatercept. I mentioned ADUI. This is the phase 3 study where they looked at the combination of ERA, of Massey and tadalafil. And the study just looked at this combination pill versus tadalafil or macitentan alone. And they showed that the pulmonary vascular resistance improved in the combination pill when they looked at it compared to each one alone, which isn't too surprising to me, but the decrease in the pulmonary vascular resistance is this blue bar. You know, the lower the PVR, the better, of course. So these 2 drugs did better than either one alone. This is a sotatercept study that I mentioned that is completed, stellar. The primary endpoint was the change in 6-minute walk distance. This is the case with many of our clinical trials. They go out to 24 months and they see if the patients that were treated with sotatercept did better than the patients who had placebo. And they enrolled patients that were on monotherapy, dual therapy, and even triple therapy. And all the groups improved, which was fantastic. The blue line represents the 6-minute walk distance in the sotatercept group versus the gray bar, which is the placebo group. And then they're enrolling all the patients into this open label long-term study called Soteria, where we'll be able to follow patients long-term to see if these benefits continue over time. The TORREY study is the phase 2 study of seralutinib. That's the inhaled medication that I mentioned earlier. They're looking at, it looked at the primary endpoint of PVR at 24 weeks. It was positive, and now they're looking to start their phase 3 study. This is a phase 2 trial of ralinepag. That's, again, this potentially longer acting prostacyclin agonist. In the phase 2 study, they had 61 patients on mono or dual therapy, and they were randomized to ralinepag or placebo. And the primary endpoint was change in PVR at 22 weeks. And the patients who were treated with ralinepag had a 29.8% reduction in their PVR, which is pretty good. Safety-wise, there was headache, nausea, and diarrhea, which are typical prostacyclin side effects that we see. Okay, so back to the case study. This is a new one, Adam. He's a 41-year-old gentleman who was diagnosed with PAH 9 months ago. And after 3 months of being on monotherapy with an ERA, he's switched to dual therapy with ERA of ambrisentan and sildenafil, the PDE5 inhibitor. Now he shows worsening symptoms, and he's intermediate high risk on the ERA ESC 4-strata risk assessment tool. And what do the ERS ESC guidelines say to do now? Refer to pH center, switch to a different ERA, add an IV or sub-Q prostacyclin, or add an inhaled prostacyclin. Very good. 34% said IV or sub-Q prostacyclin should be added. Okay. So this patient is intermediate high risk, and triple therapy is recommended by the guidelines. So the majority of you there got it right, and that the patient needs to have a prostacyclin infusion added. Refer to a pH center wasn't the best answer because hopefully they're already there at the pH center. Switching to a different ERA doesn't really make much difference. We rarely do that. They're all very similar in efficacy. Adding a sub-Q or IV infusion of prostacyclin is the correct answer. Adding an inhaled prostacyclin might be okay for the intermediate low, but the intermediate high risk patients, it's an infused IV or sub-Q prostacyclin. The patient is asking about possibly adding sotatercept, a drug he heard about on social media. What's your correct answer about this treatment? It's not indicated for PAH. It works only on monotherapy. It's not yet FDA approved, or it's only for group 4 pulmonary hypertension. Yep, that is good. 63% said not yet approved by the FDA. For PAH. I think my internet just went out. Hopefully it's back. Not indicated for PAH would be incorrect because that is what it will be indicated for if it's approved. Only works on monotherapy isn't correct. It was studied in dual therapy, triple therapy. Not yet FDA approved is a correct answer. Only group 4 is incorrect because it is not even being studied in group 4 pulmonary hypertension. Okay, so in summary, pulmonary arterial hypertension is a disease that is characterized by pulmonary artery remodeling, which eventually leads to right heart failure. The most common form of PAH is idiopathic. It does affect all ages, genders, and races. It is more common in women than men. It used to be in the younger women, and now we're seeing it in older patients as well. And nurse practitioners play an important role in diagnosing, treating, patient support, quality of life issues, advocating for patients. Lots of ways the nurse practitioners can be involved. There's multiple treatments available now, 14 to be exact, with potentially more on the way in the next few years. And then combination therapy is our most common approach. We usually start with 2 drugs in most patients. And then be sure to, if you expect to have a patient with pulmonary arterial hypertension, to refer them early to a pulmonary hypertension center. Okay, so we'll move on to the post-test polling questions. Which of the following manifestations would typically be a sign of more advanced PAH? Dyspnea on exertion, heart palpitations, syncope, or hoarseness? Okay, here we go. So shortness of breath on exertion, pre-read was the test was 71%, and on post-test, 63% got the correct answer, which was syncope. Syncope is a late sign. It's a very worrisome sign. These patients are in trouble. Okay, so Henderson, a 67-year-old male with scleroderma with recent onset of shortness of breath and unexplained fatigue, affect PAH. Yes, scleroderma is a strong risk factor for PAH. No, PAH is mostly a disease of younger women. 3, yes, unexplained fatigue is a strong indicator of PAH. Or no, this man is experiencing an acute cardiovascular event. Okay. So the correct answer is that scleroderma is a strong risk factor for PAH, and 56% got it right on the pretest and 86% on the post-test. So that's great. We had gained some knowledge. Always good to see. Okay, Emily, a 28-year-old female, is presented to her primary care physician with unexplained exertional dyspnea 6 weeks ago. She was diagnosed with exercise-induced asthma and was prescribed an inhaler. Now she presents again to a nurse practitioner complaining of worsening symptoms. She says she can't take her morning jog anymore because she gets too winded and her heart races, and she complains of an experience at work where she felt anxious and lightheaded, like she was about to faint. What should the NP do? Request an echocardiogram, refer Emily to an asthma specialist, request pulmonary function tests, or refer Emily for exercise testing. Okay, the correct answer is request an echocardiogram. Great job. 46% got it right on the pre-test and 76% on the post-test. And that's great. I often say to the primary care folks, if your inhaler's not working for your shortness of breath, think about getting an echocardiogram, and that's where we'll pick up evidence of pulmonary hypertension. Okay, according to the ERS ESC 2022 guidelines, a newly diagnosed PAH patient with functional class 2, low or intermediate low risk, should be treated with which combination therapy? Prostacyclin and a soluble guanylate cyclase stimulator, an ERA and a PDE5 inhibitor, a PDE5 inhibitor and a prostacyclin, or an ERA and a PDE5 and a prostacyclin. Very good. The answer is that patients are started on an ERA and a PDE5 inhibitor if they're lower or intermediate low risk. So that was great. 63% of you got it right, and big improvement. Okay, so sotatercept, a transforming growth factor beta, TGF beta inhibitor, is being studied in clinical trials as what? An initial monotherapy for functional class 1 or 2, a salvage treatment for functional class 3 or 4, a combination treatment with ERA, or an add-on therapy to stable treatment. Okay, this is my fault. I realized when I read this question, the answer is an add-on to stable treatment. And that, I apologize, was my fault because I didn't emphasize that the Stellar study with sotatercept did add, was an add-on therapy to patients who were on 1 drug, 2 drugs, or 3 drugs, and that were stable on those drugs. So I apologize, that was my fault that I didn't emphasize that enough. Okay, so now it's time for question and answer.
Yes, thank you so much, Dr. Kingman. I always learn so much. You mentioned, and I'll just jump in because I wanted to make a comment and kind of dialogue with you just a second. You mentioned the Reveal screening tool. Mm-hmm. Was it called Reveal? Is that right?
Yes, there's several iterations.
Reveal or Reveal Light?
Reveal or Reveal Light, yeah. Yes.
And you mentioned that basically it dictates if a patient has 12 months of life or less. I guess if they score a high score.
Yeah, if they score high risk on the risk assessment tool, they have greater than 10% of death in the next 12 months.
Oh, gotcha. Okay. So not like indicative. And I would just add here, my palliative medicine hat. That's just the perfect place for palliative medicine kind of to make that introduction with those patients. They may not need us a lot, but that's the perfect place. And I know we work hand in hand with you guys and pulmonary hypertension. So
yes.
And they're very symptomatic patients.
Right. Palliative care is a huge help for our patients, managing their symptoms, helping them with end of life decisions and getting their advanced directives in order, those sorts of things. So yeah, very good fit for palliative care.
Good plug.
Yes.
Perfect. Okay. Let me make sure I can see our screen. Yes. Okay. One question was the main diagnostic test for PAH. And just to kind of remind everybody what it is.
The right heart cath. So we can only diagnose this disease with right heart cath. Sometimes people incorrectly will try to make the diagnosis based on echocardiogram. Mm-hmm. And we know when that happens, it's wrong 50% of the time.
Wow.
There's been two big studies where they took patients and did the echocardiogram and had a cardiologist read it and decide whether they thought they had pulmonary hypertension or not, and then followed it up with a right heart cath. And those estimates or those guesses, I guess, were wrong 50% of the time.
Definitely right heart cath.
Got to have a right heart cath. Absolutely.
Perfect. How do you manage the side effects of prostacyclins?
Yeah, that's one of the challenging aspects of taking care of these patients is that most of them eventually will be on a prostacyclin and the side effect profile can be very difficult. Most importantly is to start these drugs at low doses and don't feel like you need to be in this big rush to get the dose up. If we do better if we slowly increase these doses based on how well the patients are tolerating side effects. But I always say the side effects fall into like two categories, pain and GI. So on the pain side, they can have jaw pain, headache, leg pain. Some have body aches all over. They already have pain. Oftentimes it'll be worse when we start a prostacyclin. And then GI side effects, nausea, vomiting, diarrhea, and loss of appetite. So for the pain, we try to go slowly on how quickly we're going up on the dose, try to use Tylenol if that's effective. Sometimes we use Tramadol. And then for the GI side effects, almost all of our patients are on Imodium because diarrhea is so common. And then we will use Zofran for nausea. Usually it's during the titration phase that the side effects are pretty rough. And then after we get to a maintenance dose, they tend to, if not resolve completely, but become much more manageable.
Mm-hmm. Perfect. How do I find my closest pulmonary hypertension center for my patients?
You can go onto the Pulmonary Hypertension Association website. It's phassociation.org. And they have a map of the United States, and you can click on your state and see where all the PH centers are located.
Oh, awesome. Mm-hmm. And then why would you add on any treatment to stable therapy? Was there mention of that?
No, I think that's alluding to the sotatercept study. And sotatercept not only met their primary endpoint, but they met 8 out of 9 secondary endpoints, which we've never seen in PH. But the reason is that we think that this may actually be a disease-modifying drug. And so we want to have, I suspect almost all patients are going to end up on this drug because you don't want to withhold something that can actually potentially affect the disease process. And then in the trial, patients got better. Their hemodynamics improved, their time to clinical worsening improved, their NT-proBNP improved, their walk distance improved. So even though they were stable, they got better, every group. So it was
perfect.
Impressive.
Mm-hmm. Have you seen any increase in PAH in relation to COVID vaccine or patients having COVID?
No, we have not. There are some reports that there may be more CTEPH patients, which is the group 4 pulmonary hypertension patients, because COVID is a hypercoagulable state and we saw more blood clots. And so potentially we've seen more CTEPH patients, but we haven't seen COVID causing PAH. I will say our PAH patients who get COVID tend to, take a while to get better, and in some cases don't do as well as other patients.
Yeah. This provider says, I have a lot of COPD patients. How often does COPD contribute to PAH? Should I be looking for this?
Often.
Okay.
So that's group 3 pulmonary hypertension. And if that COPD patient is hypoxic and not using their oxygen, not correcting the hypoxia, then chances are they probably do have some pulmonary hypertension. I mentioned that there's one drug for group 3 pulmonary hypertension that's approved. It's treprostinil inhaled. And it is only approved, though, for the interstitial lung disease patients in group 3. The COPD patients were studied, and the study stopped for futility. So currently, we don't have any approved treatments for group 3 COPD patients with pulmonary hypertension. And when we see them, which we do get referrals in, we try to make sure that their oxygenation is optimized to the most extent possible. So we check at night and make sure they're getting enough oxygen. Are they getting enough when they're exerting? Are they getting enough at rest? And really try to get that maximized. And that's the best thing you can do for those pulmonary hypertension COPD patients.
Perfect. And then you spoke a little bit about fen-phen, but we still see a lot of patients getting phentermine. Do we see any potential increase with phentermine, or was it just the sex or whatever the other was?
Fenfluramine. Yeah,
that's right.
It was just the fenfluramine part, and the phentermine, as mentioned, is still on the market for weight loss. It is a stimulant. There's no evidence that the phentermine part causes PAH, but methamphetamine does, and it's an amphetamine, and phentermine's an amphetamine. So you kind of wonder, but we haven't seen it. And we also haven't seen it in those patients with ADHD that are on drugs like Ritalin, Vyvanse. We haven't seen those patients develop PAH either. So I'm not sure what's different about methamphetamine and phentermine, but.
Oh, good. What if there are no close PH centers? Is it best to refer to cardiology?
It varies. If there's not a PAH center or PH center, there are oftentimes providers who have a good number of PH patients and have experience, and those are also on the website for phassociation.org. So if you can't get somebody to a center, it's too far away, there's probably a treating physician close by. If not, I would say, do the best you can as far as following guidelines and so on.
Perfect. And then finally, can a primary care nurse practitioner manage PAH once diagnosed, or do they need to stay with the specialist? What is realistic, and when should they refer?
They should refer whenever they suspect it's a PAH patient, and we like to co-manage. So we'll see the patients usually every 3 months. It kind of varies depending on how severe the case is, but we like for the patients to stay in close contact with their primary care provider, because we need help from the primary care provider with recognizing that patients might have fluid overload. Sometimes they help manage the diuretics. They can help us with side effects, let us know if somebody's getting worse. So we do work closely with the primary care doctors, and we prefer to co-manage. Whether you can do it on your own, if it's a patient with very mild PAH that hasn't progressed, maybe, but all the recommendations are to get them to a PH center. Perfect.
Well, thank you so much, Dr. Kingman. Thank you. Good information, so very helpful, and a patient population that can be very tricky and difficult. So thank you for specializing.
Thank you.
Have a great day.
You too. Bye-bye.
All right, let's move forward, everybody. Next up is Lee Simpson, where I'm excited to have her with us. Lee is an internal medicine nurse practitioner with Intermountain Health in Salt Lake City metropolitan area, completing her undergraduate studies at the University of Utah, and earned her master's degree in family practice nursing from Weber State University. She has practiced in international field research in Ghana, Africa, and presented the results of her work at the Global Health Education Consortium in Montreal, Canada. in 2011, as well as the University of Utah's Global Health Conference in 2012. Closer to home, she focuses on volunteer efforts on helping homeless and at-risk youth through education, counseling, as well as organizing donation drives. As a healthcare services professional with over 10 years of experience, Lee has expertise in wound care, women's health, and newborn intensive care. Her current work is in internal medicine and allows her to use her skilled nursing background to provide compassionate, evidence-based care to a range of patients. I am excited to hear about our next topic from Lee. It is integrating multi-cancer early detection testing, and it's with nurse practitioners on the front line. So thank you so much, Lee, for joining me.
Okay, yes, thanks for having me. Can you hear me okay?
We can.
Okay, awesome. All right, so yeah, today I'll be talking about the multi-cancer early detection testing. So let's just get started here.